Hello, everybody. I'm going to go ahead and get started with the introduction. My name is Leroy Renavar. I'm new to Array BC. I'm a medical director for engagement for scheduled care and at home. I'm going to be introducing our speaker for today, our presenter. So Dr. Olga Mora-Aldrich trained in Puerto Rico at the University of Puerto Rico. She went to medical school there and she completed her general and child adolescent psychiatry training there as well. She's previously worked at the VA and she earned an outpatient care line leadership award. She's had other awards like San Bernardino County Mental Health Commission Holiday Tea Award in 2009, and then a Janssen Psychiatry Resident Award of Excellence in 2003. She's currently a member of Array's Continued Education Committee and is fluent in Spanish and active with Array's Latino Affinity Group. She's worked for Array BC in scheduled care since December 2018. Some fun facts about her: she practices and frequently prescribes exercise and mindfulness. She is a volunteer teacher for her sixth grader character education class, and she can explain what that is if you would like in a few moments. And she's a judge for her speech and debate tournament, so she's going to be presenting on behavioral health in the Hispanic Latino population. She's actually going to, I think, explain a little bit about the title of the presentation. So I'll hand it off to her right now.
Well, thank you so much, Dr. Renavar, for that kind presentation. I just hope I'm half as good as the kids I judge in speech and debate, and then I'll just be kind of good enough for this. So welcome, everybody. Good morning to the West Coast and good afternoon here in the East Coast. And thank you for joining us for this discussion about Hispanos, Hispanas, Latinos, Latinas, Latinx, and behavioral health. So Ivan, if you could please get us to the objectives in the presentation. So this morning, next slide, please. Thank you. Yeah, so this morning, what I just want to do is share with you some highlights of a recent literature review I did about this topic in preparation for this presentation. I reviewed recent guidelines from the APA, NAMI, SAMHSA, and of course the current DSM-5 we have available as of today, with the hopes that I can help all of us increase our awareness and motivate just some further inquiry and questioning ourselves, and further the discussion on this subject and how we can best serve our Latino patients. Next slide, please. So we have a packed agenda for this morning, so let's get right to it. Next slide, please. So I want to start this presentation with a brief introduction to the concept of cultural humility. As you know, we've all been trained and we have been made aware of the importance of being culturally competent, right? Learning as much as we can about different cultures that we might encounter while we provide care in an effort to increase our knowledge and thus better serve our patients, right? So although this concept is of course still valid, we are expanding to move it forward to the concept of cultural humility. And the concept of cultural humility is basically striving to be culturally aware at all times, but starting from a place where we know and accept that culture is so broad, vast, and all-encompassing, and also has such different manifestations in every individual and impacts every individual differently. So we can't fully understand or fully embrace someone else's culture, right? We can't even fully understand impact culture has on us. We can't fully understand, but we can strive to understand as much as possible. And it is from that standpoint of being a Latina, a Puerto Rican psychiatrist, that I come to share this information with you this morning, with the goal of trying to appreciate, respect Latino as well as all cultures, honoring our beliefs, customs, and values, coming from having as guides the principles of mutual learning. So when we encounter a Latino patient or any patient, a patient from any culture, we need to both learn from each other and understand what culture means to that particular patient and how they self-identify. We also need to strive to be self-reflective so that we can understand our own beliefs, value system, the strengths that our culture brings to us, as well as the implicit bias we might have acquired throughout our lives and might be there and impact in some way how we care and how we interact with other people. And also the concept of cultural humility challenges us to understand and recognize that there are always power imbalances in existence and implicit bias there. So it is from this standpoint that I aim to share with you some aspects of my Latino culture and the Latino culture of all Latinos in the US. Next slide, please. Okay, so the numbers. We are a big group and we continue growing. So in the 60s, there were less than 6 million Latinos in the United States. But then by the year 2000, that had grown to 35.3 million, and we made up 13% of the US population. Of course, we continued growing. The most recent data that we have from the US Census stratified by ethnicity, race, and Hispanic Latino origin is still from 2010. And then we were more than 50 million Latinos and Latinas in the United States, making 16% of the population. We are expecting that this year we'll have the new results stratified by race and ethnicity from the US Census, and we'll see how many of us are in the States. Next slide, please. We expect the Latino population to continue growing. Currently, 33% of people that are coming into the United States, of current immigrants, are said to be Hispanic, Latinx. Of those Latinos living in the States, the majority, 79%, are US citizens. 16% though have a bachelor's degree or higher, and this is one of the areas where we need to continue improving and compose a barrier, which is education. So when we compare Latinos to non-Hispanic whites or non-Hispanic Blacks, our level of education as a group remains lower. And we are everywhere, in every state, in every city, in every corner of the country. You can find some of us, but the majority of Latinos are concentrated in Arizona, California, Colorado, Florida, that's where I am at, Georgia, Illinois, New Jersey, New Mexico, New York, and Texas. Of these Latinos, the vast majority of them are third generation or higher. So they've been born in this country, their parents have been born in this country. That's the reality for the majority of Latinos, Latinx in the States. Next slide, please. Could we go back one? Okay, yes. Perfect. Next slide, please. Thank you, Ivan. Okay, so now some definitions. So what does it mean to be a Latino or a Hispano, and why that long title at the beginning of the presentation? So we have many definitions as diverse as the Latino community of what being a Latino means, but as defined by the US Census, Latino, Latina, Hispano, or Hispana is a person who identifies themselves as being culturally from either a Cuban, Mexican, Puerto Rican, South or Central American, or any other Spanish culture. And they identify that as their cultural background, and that is regardless of their race. Currently in the United States, the majority of Latinos identify themselves as having a Mexican origin that makes 63% of Latinos in the States, followed by Puerto Ricans with a 9.2%, then Cubans that make up 3.5% of the US Latinos, and then all others. Among the group of all others, the Salvadoran population is the largest one, and it's expected to continue growing, and it's followed by Dominicans. Then here, another term. You've seen me and heard me mention Hispanos and Hispanas. You know, in Spanish, some nouns have a gender associated with it. So an Hispano or a Latino is a male that comes from a Latin background, and an Hispano or an Hispana would be a female that comes from this background. But then more recently, we've adopted this new term, Latinx, and Latinx aims to eliminate that binary choice between male and female, so it can be all encompassing and cover all sorts of gender identities as well. Next slide, please. So one of the things that I want you to take home from this presentation is that the Latino community is a diverse community. There is not one single Latino community. As we've already started to see, we come from many different countries and many different regions from those countries. Also, we are a multiracial group. We have whites and blacks and Afro-Latinos and Afro-Caribbeans and indigenous people and different other races that can identify themselves culturally as coming from a Latino or Latinx background. And also, even though Spanish is the main language that we associate with the Latino community, we speak other languages as well. We have a huge group of bilingual individuals that speak English as well. We have a large group of individuals that identify as Latino that only speak English because they've been born in this country, have been here for generations, and maybe have lost the Spanish in that process. And we also have individuals that maintain their native tongues from their tribes of origin. Next slide, please. So here is just a map, a visual for you to take in the many different countries and very different areas throughout the world that have Spanish as their main language and are considered part of the Latino community. Next slide, please. Okay, so how did we get here? So just a little bit of a very extremely brief historical background as of how we got the major groups of Hispanics in the US. So in the 1840s, we have had the Mexican-American War, and at the resolution of this conflict is where the modern boundary between Mexico and the US was drawn. At the time when that conflict ended, Mexico lost a significant amount of their lands, which became integrated as territories into the mainland United States. And through the Treaty of Guadalupe Hidalgo, all the Mexicans that were living in those territories that became now part of the United States could become US citizens. So we have many individuals that have, their families have been in the States for many generations, over 150 years, when they became US citizens through this process. Then later on in 1898, that's the Spanish-American War. That's when Puerto Rico was transferred to the United States from Spain. And then in 1917, through the Jones Act, all Puerto Ricans and everybody else that would be born in Puerto Rico after that acquired American citizenship. And then we've been migrating to the mainland at different times throughout history. And then in the 50s, we had the Cuban Revolution. Cuba became a communist country, and a lot of individuals sought refuge in the United States, and they had a clear path towards citizenship as political refugees at that time. As the years have gone by, the path for Cuban immigrants towards citizenship has been changing as well. Then in the 70s, 80s, a lot of different situations with political turmoil and conflicts in South America and Central America continue to fuel immigration. And then many other factors continue to fuel that immigration and desire to come to the United States, just to name a few, because there are many reasons why individuals decide to migrate, but economic hardship, poverty, violence, gang-related conflict, crime, natural disasters, as well as educational work opportunities continue to fuel migration today. And this is just a super quick overview of how we got here. Then next slide, please. So we've been talking about a lot of things that make Latinos different among each other, right? Where they come from and so forth. So important to keep in mind the immigration history of Latinos is different, and we're diverse that way. Citizenship status, education, different levels of exposure to trauma. We all are different and diverse regarding those, as well as other circumstances as well. In our diversity, we also find multiple different strengths, needs, challenges, mental health needs, and different attitudes towards care. So just let's keep in mind that Latinos were a very diverse group. Next slide, please. So we've talked about how we differ among each other, but I think we can't argue with the fact that there are a lot of things that we do share and that we do have in common, and that we call those our shared cultural factors that are kind of defining factors for the Latino community in general. Of course, there are always exceptions, and as I said at the beginning, I'm coming at this from a standpoint of cultural humility, in no way trying to further any stereotypes. But yes, I do think it's very important for us to share the things that as a group in general, we do have in common. So the first one is a sense of pride on our roots. Every time you have a meeting or a gathering of Latinos, they are saying, what country do you come from? Where are you from? And then we start colloquially fighting about famous people. Are they from your country or mine? So just to clear it up, Jennifer Lopez is Puerto Rican. We can argue about others later, but that's the kind of thing that we'll hear frequently among Latinos as we show pride for our roots and the people that come from our countries or our regions. And the other factor that a lot of us share in common is the Spanish language. And I want to spend a little bit of time on this because I think it's important. The Spanish language is a very rich language. And since we are born, we are ingrained in being verbose and verbally very expressive. And we express ourselves with our words and also with our hands and with all of our face. So we say that Latinos, we speak with our hands and also with gestures. Like there's a very Puerto Rican gesture where instead of pointing, we'll just say like, bring me that, bring me that. So we are very expressive. And as you've seen me in this presentation and will have to continue to endure, we have a tendency to provide a lot of information and a lot of details. So our language is usually not direct or business-like, it's more poetic or music-like, right? We tend to give long stories, and I frequently encounter in practice to someone who's not used to that kind of communication, the communication style might seem like circumstantial or tangential, because we do take a little bit longer of time to reach our final point, okay? Then another important thing to keep in mind about language is that being bilingual is consistently shown, has been consistently shown to be a protective factor. So one of the things that I try to instill in my family and do advise patients is that they try to maintain both languages, as it does open doors in the future and can be protective in many scenarios. So maintaining both languages is ideal. Another thing that characterizes Latino are strong family bonds. We go way beyond from our nuclear family. So when you meet Latino patients, you'll hear about the tios, the tias, the aunts and uncles, and then the padrinos, and then the neighbors that are so close to the family that they would be considered tios or tias or padrinos. And then close family friends are also included in what's considered family. And keeping those strong bonds with the extended family does usually add a level of protection and safety. Although I do have to say that it can become tricky at times and can be a source of stress for many patients, as they do feel a very strong sense of duty to their families that can be protective, as well as a source of stress for patients. And then another common and frequent tendency is to keep a deference towards parental authority throughout life, throughout the lifespan. Latinos also, we do tend to be a very spiritual people. Many Latinos also do practice very formal religion as well, and it is an integral part of many Latino individuals and families. And then the inclusion in talk about spirits or lost relatives that do maintain some level of spiritual connection or presence in the home is very common in the Latino community as well. But then just to emphasize at the end, there is no one single Hispanic, Latino, Latinx culture. Always ask the patient, how do they identify and what factors from the culture are being protection or serve to help them move forward, and which aspects might be a challenge for them as well. Next slide, please. Okay, so now we come to the point of disparities in mental health care. So unfortunately, as a minority groups, Latinos, Latinas don't get the same access to care as the mainstream. So only 34% of Hispanic or Latinx adults that have a mental illness receive care. And that's to be compared with the US average, which is 45% of adults with a mental health illness will get care. So we do have a significant disparity there in terms of receiving treatment for mental illness. A factor that we do need to keep in mind here is that US-born Hispanics across the board report higher rates for most psychiatric conditions when they are compared with current Hispanic immigrants. So Hispanics that have been in this country for several generations seem to have a higher vulnerability towards developing some psychiatric symptoms or illnesses. And that's kind of a paradox, right? Why if you've been in a more desirable place where you're supposed to have more access, well, there might be some social determinants of mental illness that are serving as risk factors for Latinos, but also for all minority communities. And some have postulated that as we get more used to the culture in the mainland, we might lose some of the protective factors that immigrants have when they've just recently come into the country, like extended family ties and having the two languages. Okay. And again, as I was saying, unfortunately, exposure to risk factors like discrimination, poverty, housing instability and food insecurity, difficult neighborhoods, challenges in education can all serve as social determinants for mental health that can be acting against a minority community in certain circumstances. Next slide, please. So continuing with some discussion on disparities, these are sad statistics regarding children and adolescents. So adolescents that come from a Hispanic background show higher degrees of suicidal tendencies and behaviors than other groups in the state. So 18.9% of Hispanic high school students have seriously considered suicide. 15.7 have made a plan. 11.3 have actually made a suicidal attempt, and 4.1 have made an attempt that has been serious enough to result in injury or poisoning or overdose that will require for them to seek medical attention. All of these percentages are higher in Hispanic adolescents than they are in white adolescents or in Black adolescent students. So those are numbers to keep in mind in terms of vulnerability for this group. Unfortunately as well, Hispanic adolescents are more likely to report having engaged in alcohol and cigarette use, more so than other minority students like Black or Asian adolescents. And also they are way less likely to receive treatments that we know can be effective and that on the long run can have a protective factor. So Hispanic adolescents are prescribed less antidepressants and less psychostimulants for ADHD. And we know that untreated ADHD has many risk factors in the future up until adulthood. And those risk factors can be mitigated by treatment. However, Latino, Latinx adolescents receive less treatment for ADHD. Next slide, please. So what barriers, why is this so? What barriers contribute to Latinos having these differences from other groups in the US? So we think that one of the main barriers is language. Whenever any of us need to seek any medical attention, we need to communicate with our providers, right? And there's no specialty where I think this is most relevant than when we're talking about mental health. You know, there's no blood test or there's no x-ray that can diagnose how we feel, the things that are being stressors or the things that are making us feel the way we do. There's no other way for the provider to know that other than from talking with the patient. So if the provider and patient speak different languages, there is a barrier, an important barrier there. Another important barrier is poverty. We know poverty is a risk factor and a barrier for an array of mental health issues, and it's the case for the Latino community as well. So 15.7% of Latinos are deemed to live in poverty, and that is compared to 7.3% of non-Hispanic whites. So a larger percent live in poverty. Also, lack of health insurance. It is estimated that around 20% of Latinx individuals don't have any health insurance. Another barrier can be a lack of cultural competence or cultural humility that might hinder establishing an effective relationship with Latino patients. Also, for some Latinos, their legal status in this country might be a hindrance to them seeking care out of fear of deportation or separation from their families. And there's also socio-cultural stigma. I just have to mention this. Anybody has seen the new Disney movie Encanto? Any show of hands? No, if you haven't seen it, you must watch it. It's the story of a Colombian family. It's a beautiful movie, and it shows one of these social cultural stigmas that we as Latinos unfortunately have about mental health, which is, there's any problem, you keep it in the family. I can almost see my grandma going like, shh, shh, shh. Those things, we don't talk about that outside the family. So expressing our needs and letting other people know about emotional situations might not be as easy. And that's a barrier that exists, I think, not just for Latinos, but it is one of the ones that we see in the Latino community as well. We also have the issue of having difficulty recognizing signs of mental illness. So different individuals might experience some symptoms and they might not be aware the symptoms are part of a treatable mental health issues. And as a group, Latinos do tend to focus more on somatic complaints rather than on emotional symptoms per se. Next slide, please. Okay, so now I wanted to shift gears a little bit and discuss how the DSM-5 is conceptualizing culture and the impact culture can have on mental health issues. So prior to DSM-5, we were all accustomed to those questions that we would frequently get on the boards, and they were about culturally bound syndromes. And these were just groups of symptoms that would tend to occur in a particular culture, and they were termed culturally bound syndromes. Now, the DSM has kind of expanded their definition and tried to be more all-encompassing and recognize that different cultures might have, yes, different cultural syndromes, but also might use different idioms, different words to express emotional distress, and maybe different cultural explanations as of why someone might be expressing distress. And let's go to the next slide so we can discuss some of these examples pertinent to the Latino community. So one of the most frequent idioms that you will hear from Latinos when they express their emotional distress is the word nervios. Okay, so it is very frequent to hear patients describe basically any psychiatric symptoms as nervios or nerves. So I've seen it used mostly to describe feelings of anxiety, but it can also mean depression and even psychosis or bipolar disorder. So sometimes as I'm interviewing Latino patients, you might ask any psychiatric history in your family. Might get a blank stare. Then alguien padece de los nervios, someone suffers from their nerves. And then you'll hear, oh yes, there was this tío that, would have periods when he wouldn't sleep and would gamble and would drink. And yeah, and there are lots of stories about that. And then he would be back and be normal for a year or so. Might have a bipolar patient there being referred to as suffering from nervios or nerves. So nervios is a cultural idiom of distress. It's a word used to express emotional distress in Latinos. And as I said, it can basically mean any psychiatric symptom, depending on how the patient uses the term. And then there is the syndrome of distress, which would be the cluster of symptoms called ataque de nervios. That's the one that would always show up on tests. And ataque de nervios, again, I've seen as many different manifestations of ataque de nervios as there are Latinos, but in general, it is an episodic manifestation of symptoms that usually is provoked by something, usually by a negative situation. It can be bad news. Someone learns that someone close to them has passed and it's been a sudden instance that can trigger an ataque de nervios. You can also have an ataque de nervios be triggered by a positive situation that would be less frequent, and it usually will start with uncontrollable crying, but it also will be associated with all and any anxiety symptom. Trembling, chest palpitations, tingling sensation, dissociation, disorganized speech or behavior. And there are circumstances in some particular groups where having an ataque de nervios under a particular circumstances might be the appropriate response. You might have families that would be surprised if someone didn't show that level of expression of emotion under a particular circumstance. But then what I think should be the carry home message from this is that even though an ataque de nervios looks like a panic attack, it does not necessarily mean the person has a panic disorder, right? So we would need to ask, how frequently does this happen? Next slide, please. Next slide. Thank you. No, next one. Yes, here. So as with any psychiatric symptom, we need to qualify and quantify how frequently is this happening? Was this just an occasional occurrence, or is this something that is happening unexpectedly? And that's what's going to give us the difference, and how much impairment is it causing, if any. And that will help us discern if this is a cause of clinical concern or if it was just a cultural manifestation of a particular situation that was stressful. Here we have other two examples of syndromes of distress. One is ataque de cólera. Cólera basically means anger, and an ataque de cólera would be an explosive anger where there's disorganized behavior, aggression. And then mal de ojo, that's like the evil eye. That is a term that can be an idiom and can be used in colloquial language, like someone looked at me the wrong way and then something bad happened. Or for some individuals, it might be something more when you qualify it, and might be part of some paranoid symptoms, as in delusional disorder. So that's here just a taste of the cultural manifestations of distress as on the DSM-5. And next slide, please. Okay, so now some words about trauma and the Latino Hispanic community. As any individual and as any cultural group, Latinos are subject to trauma, right? And I think it's important to keep in mind that there are as many sources of trauma in the Latino community as there are Latinos, right? So trauma can have many different manifestations and many different causes. However, there are some that we do tend to associate, or we have seen more often in this community. And I think it's important to acknowledge and recognize then anti-Hispanic sentiment, as well as any feeling that goes against any particular culture or group, as well as overt and covert racism, can have contributed and can be continuing to contribute to sources of historical trauma for our community. Another important source of trauma can be fear in the experience of deportation, separation from family, as well as difficult situations encountered by fleeing one's country of origin, the situations that cause that, and then perils on the way to the United States can also be sources of trauma. But I think it's important to keep in mind that although those are very important causes that we need to look out for, they might not necessarily be sources of trauma for all Latinos. And the fact that you have a Latino in front of you does not necessarily mean they have endured these types of trauma. Because again, the sources of trauma in this community are as diverse as the community itself. I do want to share some of the current narratives I see in my practice now, because I think I've learned a lot through practicing in this community. So right now I'm placed by RA in a primary care clinic that is in a suburb of LA County in California, and I do see the majority of my patients are Hispanic in origin. And in that particular community, in that particular setting, I've encountered a significant number of women that are now in their 60s, 70s, and are having to cope with the trauma of having been separated from their children when they were young. These are women that came to the United States to work, so then they could send money back to their families and eventually try to bring their kids with them to the States. And some have been successful in doing so, others have not, but this is a very, very recurrent theme that I see in many of my patients in this particular area. And the other thing I've seen fairly commonly in this clinic are guerrilla survivors. So survivors from the conflict in El Salvador are PTSD patients, just like our veterans from Vietnam or other conflicts. So next slide, please. Okay. Some clinical pearls that I've gathered in my practice through the years of things that have been helpful to me in helping out Latinos. So one of the things that I hear very frequently is patients will unfortunately have a negative experience with a particular provider, and then they won't say anything at the time, because remember, Latinos tend to have a lot of deference to authority figures, right? Kind of the same way as they are with their parental figures. So they won't say anything at the time. They'll just drop out and not come back. So again, I want to stress, don't assume, just ask. And then if you ask, take time to listen, because you know it's going to take us a little bit more time to share with you our stories. Then Latinos were very warm and empathetic as a group. So some of the things that we might consider as very professional and neutral stance in therapeutic context, Latino might find it to be kind of cold or dry. So showing some degree of warmness and empathy can go a long way. And I think that telebehavioral health is not a hindrance on that. I think Latinos are easy to engage if you show them warmth and show that you care. Another thing that I found very useful is clarifying and asking how much family involvement do they want during their care. In my experience, the majority of Latino will want someone from their family to come in at some point and serve as collateral and give their inputs as of how they think they are doing and tell you how they think the patient can do better and contribute to their care. That's what I find in the majority. But there are some that will prefer that not to be the case, particularly if having too much family over involvement is being a source of stress. So always ask, but if they want the families to be a part of it, I would take advantage of that and include them in their care. And then, as I was saying, Latino patients tend to have a very, they're very respectful, and they don't want to do or say anything that they think an authority figure might find disrespectful. So since the first appointment, I am very clear in letting them know that I'm here to help, but that the experts in what's going on with them, it's them. So they need to feel comfortable in letting me know. If there is something I have not asked that is important, they need to stop me and let me know. If they feel at any point in time that I haven't understood what they've been trying to say and I might have made a wrong assumption, I want them to feel comfortable and say, hey, doctor, that's not what I meant to say. What I was trying to say was this other thing, or you've interpreted me wrong. And I give them these examples. I also tell them, if I give you this medicine and you agree to take it, I'm hoping it's going to be good for you. But if it's not, if you have any side effects, tell me. And I specifically say, I won't be offended. I won't be offended if the medicine doesn't work for you. I won't be offended if it has side effects. I want you to tell me. In fact, I need you to tell me, because that's the only way I have of being able to help you. So I always take some time to make sure that they feel that it's okay for them to disagree with me. And I think that is helpful, not just in the prescribing of medication or recommending some therapy. It is helpful for them in life to learn that they can, in fact, disagree and advocate for themselves. That's another thing I do a lot, is try to empower patients so that they feel comfortable going to their other providers and just saying what it is that they need, because sometimes they feel that it's not something that it's not their place to do. And so I try to educate and then empower them to be advocates for themselves. And I would encourage for you to do that too. Next slide, please. So in an ideal world, we would like to be able to communicate with patients in their own language, right? But sometimes that's just not possible. You have to use an interpreter to help you communicate with a Spanish speaker or any other language with the patient. And these are just some things to keep in mind. When using an interpreter, talk to the patient, not to the interpreter, and try to continue to engage with the patient non-verbally, okay? Let's keep the questions short, so that way what we're trying to say doesn't get lost in translation. And then also, and I think more challenging, is trying to keep the patient's responses brief so that you can get an accurate translation of what it is that they're trying to say and communicate, rather than a summary from the interpreter, which might be leaving out some vital details. I think that when we're using interpreters, consider that you might need a longer appointment than usual, because if you don't have that extra time, then basically that's another barrier to care. We're giving the patient that speaks a different language half the time that we would give someone who speaks English. And then avoid using relatives as interpreters, particularly minors. We see frequently that minors can serve as interpreters for their parents in social situations, but in medical situations, and particularly behavioral health, I think that would be best avoided. And then also try to avoid delegating excessively on maybe junior members of the team just because they speak Spanish or speak another language, so that patients can have access to all the degrees of expertise within a team, even if it means having to use an interpreter. Next slide, please. And then just a final word here on how I think, and the literature thinks, that telebehavioral health is a great means to breach the barriers to care that we can have with the Latino communities. It's consistently shown to improve access and to help deliver good quality care in situations where patients might not otherwise receive it. And I just wanted to say that in my experience, Latino patients enjoy tele-interventions a lot. They feel comfortable with it, and I consistently hear by the end of the first session, "Oh my God, doctor, it was as if you were right here in the room with me." So I think telehealth is to be seen as something that will enhance access and availability of care for Latinos and other hard to reach communities. Next slide, please. Okay, so here just a list of resources that have very good information in Spanish for you to hand out to your patients. It's been a pleasure sharing this with you. Before we go on to the quiz, I just wanted to know if there were any comments or questions that we should tackle. Ivan.
No questions in the chat so far.
No questions. Okay. Okay, so please, let's go to the quiz. We have here a clinical vignette that then you could read and go through, but then let's go to the quiz. So let's see if we've learned through the presentation. So according to the 2010 census, the Hispanic, Latino, Latinx population is estimated to be, is it 20 million, 30 million, 40 million, or over 50 million? And the answer is, Ivan, next slide. It's over 50 million and we continue growing. Next slide, please. So the Hispanic population in the US, A, is expected to reach its maximum level in the next 5 years, then decrease. B, is made up of mostly undocumented immigrants. C, is expected to make up 28% of the US population by year 2060. And D, is uniformly distributed across the 50 states. Let's see what our answer is. Expected to make up 28% of the population, right? So we're growing and continue to do so. Next slide. True or false? Hispanics share one common culture, having Spanish language at its core. And I hope we all know that this is false, right? We are a multicultural group with many languages and many cultural manifestations. Next slide, please. One of the factors that contribute to diversity in the Hispanic community is A, multiple countries of origin, B, different immigration pathways and citizenship status, C, multiple languages, or D, all of the above. The answer is all of the above. Next slide, please. Then the term Latinx refers to A, Latinos from Generation X, B, young Latinos and Hispanic millennials, C, it's a term that eliminates the binary choice between male Latino or Hispano and female Latina, Hispana, or none of the above. And we all know that it is C. It eliminates that binary choice and it's a more inclusive term. Next, this is a sad one. Hispanic high school students, A, are less likely to attempt suicide than white high school students. B, are less likely to be treated with antidepressants and psychostimulants. C, less likely to initiate alcohol or cigarette use. Or D, none of the above. And unfortunately, it is B. Very good, Dr. Nicole. Thank you for contributing to our quiz. Then next slide, barriers in receiving adequate behavioral health care for the Latino population include a lack of health insurance, B, providers' lack of cultural competence or cultural humility, C, legal status, or D, all of the above. The answer is all of the above. Next, true or false?
I'm sorry, before you move on, can I ask a quick question?
Sure.
So you mentioned that there are often somatic symptoms may present initially. So when we are screening patients, Hispanic or Latino patients, should we be asking more about physical or somatic symptoms up front rather than just the more typical psychiatric symptoms?
I would say definitely yes. And I would also say that in terms of us getting referrals, let's say I work at a primary care clinic, I think we need to do a good job at letting primary care physicians be on the lookout for this, because it might be the patient that will present seeking care for those physical symptoms, which might be there, but they might be a manifestation of deeper issues or just somatization. So we need to raise awareness within our referral base so that primary care doctors are savvy in recognizing that Latinos might not necessarily bring up those symptoms upfront. So yes, we should seek for them, and also educate our teams and our referral base on that reality. I hope I've answered your question.
No, that's great. And I mean, even just thinking about some of the primary care partners we work with, particularly those that have large Latino populations, like we have a lot of federally qualified health clinics in Illinois. And so, you know, maybe this is something we should be sharing with them.
Yeah, so I think that that's where collaborative care will yield good results, right? Because Latinos are also way more likely to have a primary care doctor and not have a behavioral health specialist. So where we meet them in that point of care and that point of access is where we need to be savvy about screening them as appropriately as possible.
Thank you.
Any other questions or comments, please? Okay, if not, we can move on to the next question. Okay, according to the DSM-5, an individual who suffers an ataque de nervios should be diagnosed with a panic disorder. And the answer is false. It might be the case, but it might not. Next slide, please. Okay, regarding trauma and the Hispanic population, which of the following is true? A, anti-Hispanic sentiment, overt and covert racism have been sources of historical trauma. B, sources of trauma are as diverse as the Hispanic community. Both of these or none of these? And the answer is C, both. Next question, please. Okay, best practices when providing care to Latinos. Should we use a biopsychosocial cultural model? Should we consider cultural factors that add either vulnerability or resilience? Should we consider cultural factors that impact the relationship between the individual and the clinician? And the answer is all of the above. Well, that was our last question. I am so grateful to having had this opportunity to share these thoughts with you. Does anybody have any questions or any comments?
I just wanted to say, I thought it was so funny when you were talking about Latinos' expressiveness and extended family, and it very much reminds me of African-American and Caribbean gestures, and even like pointing with your lips. And I'm like, yeah, my husband's from Barbados and does that all the time. So it's just funny that there's many similarities across cultures. Across cultures.
And then remember that among Latinos, we also have a big community of Black Latinos, Black Afro-Caribbeans. So yes, we're all in that huge, beautiful culture. Any other questions or comments? Well, if not, it's been a pleasure spending this time with you. The presentation will be made available to everybody that was here, and hopefully we'll learn soon about the possibility of claiming credits for participating in this activity. Our admin team will share that information with us via email soon, hopefully. So thank you so much, and I hope you have a wonderful afternoon and wonderful rest of the day.